Hello and welcome everyone. We'll get started in just a moment, giving folks just another couple seconds to join. Welcome everyone. We'll go ahead and get started. I'm sure we'll have some more folks joining us shortly. I am Lauren Berner-Davis. I am the Director of Implementation Research at the National Healthcare for the Homeless Council. I'm here with my colleague Joey. If you have any technical issues, you are welcome to reach out directly to either one of us. I see Kat introduced themselves in the chat. We would love to have folks introduce themselves. Let us know where you're calling in from. Everyone should have access to the chat. We'll be using that throughout the time to engage. We also have a Q&A pod. And if you don't mind putting specific questions in the Q&A section, that will really help us to be able to filter through so that we aren't missing any questions that might have come through in the chat. So chatting with everyone, of course, use the chat, specific questions, try to use the Q&A pod if you can. Everyone is muted at this point. And so again, really encourage everyone to do some intros in the chat. This session is eligible for continuing education. You should be able to get that link through the resources tab. And I'm also going to put the information in the chat now. But without further ado, I want to introduce our really incredible presenters today. We have Dr. Travis Baggett and Faye Kudari from the Boston Healthcare for the Homeless program. They are here to share some of the recent work that they've done on a Patient-Centered Outcomes Research Institute grant, or PCOR, and also share some of their lessons learned, and we can all think about how we can engage more in this type of work. So I will hand it over to Travis and Faye.
Thank you so much, Lauren. It's great to be here. Welcome, everybody. Can everybody hear me okay? Maybe a thumbs up from our, yes, great, awesome, fantastic. So I would say good to see you. I can't see you. Hopefully you can see me, so that's good. I'll look forward to hearing your questions later on and your comments in the chat as we progress. My name's Travis Baggett. I'm the Director of Research at Boston Healthcare for the Homeless program, here with Faye Kudari, who will be co-presenting with me. So I'm going to kick us off. Our talk is building capacity for patient-centered outcomes research in healthcare for the homeless settings. So as we get started, go ahead and type into the chat. I know some of you are introducing yourself. Type into the chat what patient-centeredness means to you, or what does it look like to you when it comes to research? Maybe you don't know, maybe you have a good sense of what that looks like. In a few words, type in what you think patient-centeredness looks like or could look like when it comes to research. All right, next slide. We'll go ahead and get started, and we'll circle back on patient-centeredness in a moment. Just to acknowledge up front that what we're presenting, the program that we're presenting, the content was funded through a Patient-Centered Outcomes Research, or PCOR Eugene Washington Engagement Award. With that award number, the statements that we're making here do not represent PCOR or any of its people. They are our experiences and our statements. We also want to thank Dr. Lillian Gelberg at UCLA, who's an absolute giant in the world of homeless healthcare research, and from whom we and many others have learned a lot over the years. She helped to guide us in this project. All right, so our learning objectives for today. By the end of the session, hopefully, and I see people rolling in with their comments as we go, so this is awesome. Keep them coming. I can see already we've got some experts in patient-centeredness here. So by the end of the session, hopefully you'll be able to define patient-centered outcomes research and comparative effectiveness research. Some of you probably can do this already, but we want to level set here and also recognize the importance of patient engagement in both of these things. The second is to describe the key components and delivery of a healthcare for the homeless tailored PCOR, patient-centered outcomes research curriculum for staff and patients. The third is to identify how PCOR and stakeholder engagement can be incorporated into an organization's research agenda. In our case, it's Boston Healthcare for the Homeless program. And to name strategies for promoting and sustaining patient-engaged research activities within an HCH program. All right, next slide. Keep those comments about patient-centeredness coming in. So what do we mean by PCOR and what do we mean by comparative effectiveness research? So in many ways, these are different. In many ways, these are very much interrelated. And the PCOR agency really tackles both. Patient-centered outcomes patient-centered outcomes research refers to research where the questions that are being asked and the outcomes that are being measured are meaningful to patients and caregivers. That sounds obvious, but it hasn't always been a part of how we do research in an academic setting. Comparative effectiveness research, on the other hand, is research that compares two or more medical treatments, services, practices, interventions of some kind to help people make informed decisions about their health. Now, with comparative effectiveness research, or CER, we're usually not coming up with brand new things. These are things that are tested, they're proven, they're known to work. And in fact, it's not clear you could choose any number of things. It's not clear which is the right choice in the right moment for these patients. And so it's comparing established things to see what are their relative benefits and drawbacks compared to each other in a particular setting. So the Patient-Centered Outcomes Research Institute is a federally funded but non-governmental agency that funds PCOR and CER, and their interest is in combining those two types of research to inform patients, to help inform patients to make informed decisions about their health and their healthcare. Next slide. And I mentioned that PCOR here. PCOR describes itself as an independent nonprofit research funding organization that seeks to empower patients and others with actionable information about their health and healthcare choices. They are the largest funder of patient-centered comparative effectiveness clinical research in the US, and they have an emphasis on engagement of patients and key healthcare decision makers across the continuum of work. Next slide. So what does engagement throughout the entire research process mean? Well, it's in many ways self-explanatory, but let's really break down the research process sort of from beginning to end, because it is a process and it is very much cyclical. Research starts, just like any good sort of project or endeavor, it starts with developing a really good question. And for a long time, researchers decided what those questions should be. It's like, well, should we choose this pill or that pill? I'm interested in this pill, and I'm going to choose this pill, right? But now patients inform this. What health topics or healthcare issues are important to you? Next, we're going to choose a study design to help answer that question, right? And again, we want patient, participant, consumer, stakeholder investment in that study design decision. It may be that a randomized trial would be ideal, but it may be that stakeholders are not willing or able to really see how a randomized trial could be done, and they really want a different option. We then need to think about how we collect data as part of our study design. So we can collect data through surveys or through tablets or through phones or in-person conversations. We can audio record, we can video record, we can do closed-ended questions, open-ended questions. We have a lot of choices. Patients should play a role in guiding that because they may have preferences that really impact the quality of the data you get. Then there's the analyzing of the data. Now, we need to make sense of the data we collect. We often collect way more data than we are often able to present. And data, even though it's very objective, requires some amount of interpretation to really understand what this means. And so when it comes to analyzing the data, yeah, the statisticians and the people with expertise are crunching the numbers, but we need help making sense of those numbers, especially if the findings don't really add up to us. And so we can say, well, can you help us understand this a little bit better, right? And draw conclusions from it. So what do you think is going on here? And what do you think we should take from this? And then last, how should we share these findings back out to people for whom this matters, right? So patients are engaged throughout this research process. Next slide, please. All right, so why engage patients? Well, there are benefits to practice, benefits to researchers, benefits to patients and community partners. From benefit to practice, the findings can be more relevant. It can improve the feasibility, acceptability, and quality of the research. It could improve uptake of the findings in clinical practice. Benefits to researchers could include gaining a better understanding of patients' lives and clinical processes. And it could also benefit them with their ability to continue to engage people moving forward. Benefits to patients and community partners could include developing skills and improving their own health and trust building through meaningful partnerships in decision making throughout the study. Next slide, please. All right, so we want to offer an example of what a patient-engaged research project can look like. And this was the PCOR study that Howard Padwa and Lillian Gelberg were part of. This is patient-centered housing options, outcomes, services, and environment study. So this is a unique and I think great example of a patient-engaged research because they used what they call the lived experience group or their LEG group. It informs several aspects of the study, including guiding data collection. The consumers were actually able to say, we don't want our phones tracking us everywhere we go. That's private, that's personal. Developing new ways to collect data. And they suggested, why don't we have people take pictures of their life as a way for the research team to understand what's going on? And then helping to interpret the results. So why might there be lower than expected reported rates of substance use in this study? Well, people were afraid of losing their housing if they admitted to using drugs while they were involved in the study. Next slide. So at Boston Healthcare for the Homeless program, I think honest moment of self-reflection. I think we have a rich tradition of research spanning many decades. I've shared some screen grabs of some high-profile studies that we've done related to mortality patterns in our patient population over the years. But I'll be honest, despite the amount of research that we've done, very little of the research that's come out of Boston Healthcare for the Homeless program historically has been truly patient-centered and patient-engaged. And we recognize that's an area of improvement for us. So that led to our PCOR grant application, next slide, that had the following three aims or objectives. The first was for us to, over this 2-year period of time with this award, to be able to adapt and deliver training in patient-centered outcomes research for both staff and patients at BHCHP, to develop a BHCHP research agenda that emphasized PCOR and CER, and to build infrastructure to sustain patient-centered outcomes, PCOR, CER at BHCHP. Those are the three components of what we did. We're going to walk you through those now, and I'm going to turn it over to Faye.
Thank you, Dr. Baggett. So I'm going to be describing the core trainings that we implemented in order to increase individuals' capacity at Healthcare for the Homeless. We had longitudinal and drop-in sessions for both patients and staff. And the goals for these sessions were to improve general research literacy. We had people coming from many different backgrounds who maybe had familiarity with research from their own experience or education, and some people that was completely new to them. We wanted them to build confidence in being able to partner and advise researchers, and also have specific knowledge about patient-centered outcomes research and the nuances involved in that type of work. So over the course of a year, we had staff learners joined for a longitudinal cohort. They met monthly over 12 months. We had 13 stable members, including providers, nurses, social workers, case managers, administrators, and even an IT training manager. So we tried to get a very diverse group of people to join these sessions. And we included interactive presentations, activities, which you'll see in future slides. And we got these folks by sending out an interest form and then ensuring that people were interested in the topic and that we had a representative group. Our sessions were an hour and a half every month, and people received a $100 incentive to participate. And then we also held a number of drop-in sessions. We had 2 over the year to reach additional staff who weren't able to otherwise attend these longitudinal cohort sessions. We held 1 online and 1 in person, and these were open to all staff. And again, we made sure that it was interactive, and we had activities and breakout groups so that people could really apply the knowledge. So these are examples of what we presented during the monthly learning sessions. And so you can see that the topics ranged very widely. We talked about what patient-centered outcomes research is. We talked about some topics related to research in general, and also tried to drill into specifics to our context. So working with people who are experiencing homelessness, what is the history of mistrust between researchers and our population, and how do we overcome some of these barriers and build trusting relationships. And then we even went into some details around biostatistics and sampling and recruitment and retention. So you can see that the topics ranged greatly. We had a lot of ground to cover. And then our drop-in sessions were more general. So we talked about what patient-engaged research was and PCOR. It's very important to note that the folks that developed the content and also facilitated, we had a wide range of people who contributed to these sessions, who were data analysts, Dr. Baggett, we had researchers, we had our chief equity officer, grant and compliance manager, and director of quality all contribute to the content as well as facilitating discussions. So this is an example of one of the slides that we had for our presentation talking about research methods. And so here we talked about the research question and how it led to the research method. So for example, what type questions in your research question typically lead to quantitative methods? So for example, what combinations of drugs are most commonly used by our patients? And so you may see quantitative methods being used versus why questions that are getting at qualitative data and understanding, for example, why do our patients use different combinations of drugs? So this is just one example of some of the content that we presented. Some more examples include, we use this in our drop-in sessions as well, helping people understand what patient-centered outcomes research was and CER, and distinguishing it from other types of research questions. They're very specific criteria for PCOR and CER. So we gave examples, and then we also had people break out into groups. And so they could talk about what kinds of questions that were important to them and their areas of interest and come up with their own research questions. So this is one example of a comparative effective research question. Typically, the formula looks at comparing 2 evidence-based interventions. So one example was among Boston Healthcare for the Homeless program patients with type 2 diabetes not controlled by metformin alone, what is the effect of adding insulin or a GLP-1 agonist on diabetes, self-efficacy, symptoms, and quality of life? So those 3 outcomes really highlight what distinguishes patient centered outcomes research from other types of research. And this was really fun to do in groups because, for example, in our drop-in session, our in-person drop-in session, we had our flagship clinic come and attend that session, and they're part of multiple primary care teams. And so they kind of more or less group themselves in those primary care teams. So we had the OBAT team, or the office-based addiction treatment team, coming up with examples and research questions that were specific to addiction care. And we had nurses, secretaries, benefit coordinators, and providers all together collaborating on these research questions. I mentioned earlier that we did get into some details about biostatistics and data analysis. And so this is an example of one of the slides that we presented. So after talking generally about research, we also held sessions and used examples from homeless health research to talk about biostatistical methods. And finally, I'll show an example of one of our sessions, which looked at how to develop a grant proposal. And so, for example, this is a PCOR funding announcement. And so the compliance officer, as well as a few others who have experience doing grant writing and research grant writing, came up with, presented this example, and we went through and talked about what are the main components in a funding announcement, what are best practices for grant preparation, writing, how to create a timeline, and also get the right people in the room to have a successful grant application. So I mentioned earlier that all our sessions involved interactive learning techniques. This is one example of how we did brainstorming in order to discuss ways to engage patients in research, as well as barriers and facilitators of research engagement. And we noticed that it was very relevant for people who, especially those who didn't have a background in research and were more familiar with the clinical setting. It was really relevant for them to draw on what they knew about meeting patients where they're at, as you all have mentioned in the chat. I noticed a lot of people mentioning meeting patients where they're at. Any hesitancy to engaging in clinical care for a patient experiencing homelessness, a lot of those barriers also translate into hesitancy to engage in research. And it includes other barriers that we may be familiar with, such as language, physical barriers, fear of how their personal information will be used, stigma, gaps in health literacy. And in terms of facilitators, people noted that it would benefit patients perhaps to be working with researchers that looked like them. And we know this is the case as clinicians as well. Building trust and rapport and setting clear expectations about the benefits and the limitations of the study, and ensuring to provide incentives and being thoughtful about how we're using people's time to not burn them out. So those were some of the questions that came up, and please feel free to continue adding comments in the chat about what you feel are barriers and facilitators of patient-engaged research that perhaps we haven't mentioned. So in terms of what we learned and what we found from the staff sessions, one of our goals, as I mentioned earlier, was to improve general research literacy. We had people coming from varied backgrounds, and we had a lot of ground to cover. So we asked a series of questions. We called it our impact evaluation. In the beginning of the learning sessions, 6 months into them, and then a final one at the 12-month mark. And one of our questions that we asked to address this goal was, or a statement rather, that people rated on a Likert scale to agree to disagree, was, I can find answers to my own questions using research. And we found that over the course of the year, people had a steady increase and confidence in their ability to answer their own questions using research studies. And one person even mentioned that now I read the methods section while reading a research article. And this was a big win for us because that meant that people were gaining confidence in being able to understand the concepts in a research article. They weren't intimidated by the research section perhaps, and had more familiarity with the words being used. And then one of the other goals that we had was to build confidence in partnering in research. So that's a really important aspect to building capacity. And the question we asked for this is, I can be a part of the research process. And people already felt fairly confident, but you can see by the end of the year, 100% of the participants felt confident that they could partner. One person even said that the learning sessions made them realize how capable they could be when cooperating in research, which was something they thought they wouldn't be able to do. And finally, for our third goal, we wanted people to really enhance their knowledge of patient-centered outcomes research specifically. And the question with that was, I understand what patient-centered outcomes research is. Mind you, this impact evaluation was taken after our first session. So by then, most people had an idea of what it was, but you can see certainly by the mid-year and the final session that people felt confident about understanding what patient-centered outcomes research was and how it distinguished itself from other types of research. One person said, I'm part of a behavioral health group interested in grant research opportunities. I will bring this learning to that group. And so that was great to get that feedback, because that meant that people were then sharing what their learnings in those monthly sessions to other parts of the program, which was the whole point of this, was to bring other expand capacity to individuals throughout the program. So as facilitators, there were a number of things that we observed and lessons that we learned. And so in terms of both the longitudinal and the drop-in sessions, we learned that we had to set clear expectations and talk through with people the capacity to partner versus conducting their own research. And what I mean by that is people had really wonderful ideas about what kinds of things they wanted to see improved and what kinds of questions they wanted to ask our patients. And while the longitudinal staff participants are not full-time researchers, we wanted them to feel like they could be a meaningful partner, and also empower them to perhaps conduct their own quality improvement projects. We also, as I mentioned previously, implemented interactive activities to apply the knowledge, and we saw that that was effective. And then we got feedback that some of the information was a little bit too in the weeds at times, and that it would get people lost. So we really had to strike a balance between giving high-level information and speaking in general terms while also making sure that the information was relevant to their context. We received a lot of feedback both after each monthly session, as well as in feedback forums that we hosted before each session. So that way we could give people a sneak peek into what's to come, and also ask them what was landing and how we could improve the content. So a lot of this we were incorporating throughout the year. And we found that collaborating with content experts, as I mentioned, to develop and lead the learning sessions was very effective. We tried to use as many real examples as possible and reinforce the concepts with handouts and homework, which people, engaged with in varying degrees, and giving people a chance to kind of pull out the most salient points at the end by summarizing key points. And we also acknowledged that people really had an interest in learning more. So for example, in the drop-in session, especially the one in person, people were asking us afterwards, like, okay, when are you going to come back? When is there going to be a part 2? They wanted to get more detail and talk about what their research questions were. So those were all feedback that we received from the staff sessions. Now, in parallel to the staff sessions, we had patient learning sessions. So similarly, we had a longitudinal cohort, which met monthly for 1 year. These were comprised of 9 members, and it was our Boston Healthcare for the Homeless Program Consumer Advisory Board. So our Consumer Advisory Board has a long history of advising our programming and priorities at BHCHP, and they were a group of people that we know have a history also of being able to attend monthly meetings, sit for an hour-and-a-half meeting, and participate in sessions. And so this was the most appropriate group we found for delivering this type of content. For our drop-in sessions, we acknowledge that 9 members is not necessarily representative, and our CAB members, most of them have been housed for a period of time. So we wanted to make sure that we were reaching a wide range of patients. So we held 6 patient drop-in sessions over the course of a year, which allowed us to reach an additional 50 people. And we went to where patients are at. As you all know, that's kind of how we need to do things in homeless healthcare. And so we went to our respite program, we went to shelters, we engaged in addiction support groups that were already happening, so we could plug right in and deliver the content through we had a skit, we had interactive poster breakout groups so people could walk around and kind of learn the content at their own pace. And we made sure to include handouts, quizzes, prizes, and all our material was translated into Spanish, and we had translators with us as well during the sessions, so that way they could also be included. Similarly to the staff sessions, the longitudinal cohort received $100 to participate each month, and the drop-in sessions participants received $50. So we had a range of topics for the patient sessions as well. They differed from our staff ones. We discussed what were research priorities, questions, and outcomes. We talked about research ethics as well. And we talked about how they could get involved in research and how they could support recruitment. We discussed language and culture in research study planning. And we also had the leg group, which we talked about earlier, that Dr. Baggett gave in as an example in the beginning of the presentation. We actually had some of the leg members come and talk to our part group, is what they were called. And it was very impactful for them because they had yet met with anyone who had been an advisor to research, a patient advisor. So they were able to ask questions and really see themselves as being potential advisors as well. So this is an example of one of the slides that we shared in our longitudinal session. A lot of our content was focused around helping the part members, the advisory group, shift their role from thinking of themselves as research participants to being an advisor in research. And as I mentioned, they already had a history of being advisors to the program. So this was now just bringing their advisory hat into a new context. So the different ways that they could advise research was to represent patients and inform the research team about the needs and perspectives of patients, making sure that the research question was relevant, connecting people. So the part members mentioned how they were more likely to trust or be involved in research if it was coming from another patient. That's when we were talking about research recruitment specifically, and also encouraging patient engagement by working together and advocating. So this is another example, and this study, this was an example of research and how it changed practice in real life. And so the goal of this study was to develop new programs to increase access to care for pain, especially amongst communities that experience stigma and discrimination. And so we try to incorporate examples, real life examples, as much as possible. So I'd love for you to put in the chat. We asked our PART members what they thought about these posters for recruitment. And these are real posters that were used for a research study. And we asked them what they found was effective about the poster, what they felt made it accessible or not accessible for limited English proficiency audience, and what they felt could be improved. So this study was done by one of our clinicians and researchers at Healthcare for the Homeless, a qualitative research study to understand the experiences of Spanish-speaking patients coming to the US. And so I encourage you all to put in the chat what you think is effective or perhaps not as effective in this poster. And this is just one example of the type of interaction and brainstorming that we did in our sessions. In terms of hearing, receiving feedback and our evaluation, we found that the PART members, distinct from our staff members, really benefited from being part of a group and having that group participation. They talked about how they felt heard and seen and how that was really important to their motivation to stay engaged in these sessions. One person even described the friendship that they gained by attending the sessions. And people also talked about both ends of the spectrum. So people who were perhaps more vocal, they described how they learned more to listen while others were sharing. And then on the other hand, there were PART members who were perhaps more shy or quiet, and they talked about how they were able to share. And that was really important to us, that everyone had a chance to express themselves. And so, for example, one person in their evaluation said, encourage each other to raise your hand if you do not understand something. And to us, that meant that the group was encouraging one another to be part of the conversation. And they wanted to make sure that it was an environment that everyone could be heard, everyone's voices could be heard. And we incorporated a couple different things when we heard this type of feedback. So we encouraged patients who were perhaps more quiet to hand out handouts or slides. We had one of the PART members note when people were raising their hands to make sure that we got to each person, and to minimize crosstalk. And these were just some of the ways that we encouraged people to engage. And then we also had, because sometimes people wouldn't necessarily feel encouraged to speak, we also set ground rules at the beginning of each session. So that way everyone was on the same page, and folks responded well to these changes that we made. As I mentioned earlier, one of the important shifts that we wanted to communicate was expanding their role from a participant in research to an advisor. And by the end of the 12 months, 100% of participants said they could see themselves being involved in research in the future. One person even said, it's a great thing. I feel like I could be a good advisor, and it's great we have a voice in research. And finally, we wanted to help them expand their understanding of what research means. One person said, research is not just surveys. And so I'm going to move on then for the sake of time. In terms of the questions that we asked in our impact evaluation at baseline, 6 months and 12 months, you can see that for each of the impact evaluations that we conducted, there was an increasingly higher percentage of people who responded yes with the following statements. my community is valued when it comes to health research. My opinions matter in health research. I can partner with healthcare researchers and give them advice. I can participate as an advocate, and I'm comfortable talking about research studies. And we found that perhaps this didn't necessarily reflect our observations. I'm talking about specifically the last one. I'm comfortable talking about research studies. We did not get the sense that all of them felt comfortable discussing research studies, since some of them had perhaps a mixed understanding of the examples that we used, but we certainly were pleased to see that people self-reported having confidence in being able to be involved and understand research studies. So for the facilitators, we had a number of lessons that we learned, and we compiled this in a facilitation guide for other healthcare for the homeless programs to use if they too wanted to conduct trainings about patient-centered outcomes research. And some of these lessons that we gained was that it was important to reinforce concepts with handouts and periodic reviews. So at 6 months and 12 months, we had a review of the content to date, and people really said that they benefited from that and asked for handouts. Of course, we did interactive activities as much as possible using real life examples. And it was really important for us to read the group energy and respond to in the moment needs, which is why it was best for us to make it completely in person rather than having a hybrid model. We tried that. It didn't work because we weren't able to then understand the dynamics going on between people. Sometimes the person on Zoom would then interject and interrupt what was happening, or the opposite, they would completely fade into the background and not be able to understand the content. So that was really important. And of course, creating space for self-disclosure. It really struck me how much people used their stories in order to relate to the content. And we found that it was really important for them to feel heard and share those stories, whether or not they were directly related to the content that we were sharing that day. It just provided that overall container for people to feel safe. And I'm gonna hand it back to Dr. Baggett.
Great, thank you, Faye. So Faye did a great job of outlining the curriculum directed toward the PCOR curriculum directed toward staff, and the PCOR curriculum directed toward patients. And each of those were the real major component of this PCOR award. I'm going to walk you through the two other components that are in many ways considerably shorter to present, but kind of bring the discussion full circle. So we felt it was important in all of this to develop a research agenda at BHCHP that emphasized PCOR and CER, at least to some extent, or at least think about how to do this. And so we embarked on this process, which involved collaboratively developing, with input from multiple stakeholders over several months, a clearly defined research agenda. We got input from staff as well as patient learners and from key organizational leaders. Next slide. The challenge was, how do we put together a research agenda that is specific, that's clear, but also is somewhat evergreen, right? If we write an agenda based on the issue of the moment, let's say it's COVID, well, in 3 years, that might not be as relevant. So we wanted to create an agenda that incorporated PCOR, but also had an evergreen quality to it. So we identified 4 sort of key areas of emphasis for our agenda, or priority areas. Priority area 1 was to more rigorously and consistently include patient-centered, stakeholder-engaged research methods. That's methods that we've just described to you, engaging consumers and stakeholders throughout the research process. The second pillar is to focus some energy on considering the remarkable heterogeneity and diversity of people experiencing homelessness. We know that homeless populations are not homogeneous, that this is not a monolithic population. And we know from our experience that we need to understand the many, many subgroups among the population that we serve, particularly individuals who have intersecting or intersectional vulnerabilities, to identify what their needs and what their particular needs are, and how we as a program can respond to those needs. Third priority area was to consider and dive into more carefully health conditions that we know disproportionately impact our patient population. And that could be because they're either more common in our patient population, or they're not more common, but they're just more difficult to manage. A great example of that would be diabetes. And then the fourth area of emphasis was in really trying to dig into and better understand homeless healthcare innovations. At the end of the day, we are a clinical program. And what we do clinically is really, and what many of you do as well, is it clinically about innovation. It's about how we develop clinical models that respond to the needs of our patients, often through non-traditional means. So we want to, as an area of emphasis, examine the impact of these care innovations in order to meet the needs of people experiencing homelessness. This is what came out of our research agenda process. Then finally, we wanted to look toward the future. Okay, how do we sustain? We've got this great thing going. We've got some money from PCOR to teach people about PCOR and CER, to identify a research agenda for the future. How do we sustain this moving forward? And we identified 3 strategies that we can do that. First strategy is to create consistent opportunities for PCOR stakeholders to be part of ongoing research. And that would happen through 2 means. One, that we decided we would keep a registry of our PCOR curriculum alumni, those staff and those patients who showed up every month for a year to learn about research, to see if they want to be interested in involving and advising researchers who come to us with project proposals. Hey, we've got someone who went through this whole training who can help you out. Here they are, right? And then finding a way to connect those researchers with those stakeholders, with those PCOR educated stakeholders early in the process. So not late, not as an afterthought, but researcher from big academic institution comes in and wants to study something. Hey, we've got someone we can connect you with here in our organization who's an expert on that. They've been trained in PCOR. We're going to make the connection at the idea stage rather than at the execution stage. Next slide. Second strategy is to promote best practices for consumer engaged research across our various partnerships. So we want to provide researchers, when researchers approach us, which frequently happens about doing research with our population, we want to provide them with a copy of our agenda to say, okay, can you align your question with our priorities? And also, let us give you some information about what we've learned on how to engage consumers through this process, because we think it will benefit you and your research. Our other strategy, or our other action item within this strategy, is to reinstate something we started before the COVID pandemic, and then it kind of fell by the wayside during COVID for clear reasons. But we used to have quarterly research in progress seminars that I hosted through the BHCHP Institute, where BHCHP staff could come together and discuss ongoing research projects. And so our goal is to reinstate that now that we're moving back towards slightly more normal work schedules. All right, third strategy is to more regularly disseminate our research findings back to the community. First and most concrete way we're going to do this is on May 27th, we're going to have our first ever annual research day for researchers within BHCHP or affiliated with BHCHP to share preliminary or final results of research studies or QI projects that they have going on. We're going to emphasize the PCOR-oriented work that's being done. But it's really amazing because we've got 26, I believe now 26 individuals presenting projects on this research day. And so really, really amazing turnout for this, and we're really excited. We've also decided that we want to incorporate more actively plain language summaries at 2 stages of our research process. First, when people come to us and they want to conduct research, we have a proposal process for them to do that. Within that proposal process, we are now going to ask them to develop a plain language summary so that we could hand that proposal to a consumer and say, this is what this researcher would like to do. Then secondly, when the researcher has done their work, hopefully in partnership with us, and they want to disseminate their findings and their results, they have a plain language summary describing what those results are that we can then share back with our community. Next, I want to end with the notion, we started with the notion of what patient-centeredness means. And so it felt appropriate to come back to and end with some words from our consumers that we gathered and heard along the way throughout this 2-year PCOR grant process. Next slide. One, when posed with the question, what is the most important thing for researchers to know about you and your community when they are starting a new study? We heard responses like, that I'm a person with lived experience who's been housed for some years, but still have my issues with mental health and long-term illness. I want them to know who I am and where I come from. And last, that we need to trust each other. So it's not just about what research do you want to do, but it's, can I trust you? Can I trust you with my story? Can I trust you with my information? Next slide. In response to the question, what should researchers do to work better with you and your community? Respondents said, explain what the research is about. And that sounds really obvious, but sometimes we get quickly into jargon, and explaining it in plain language is really important. Next. Do more outreach about research. People want to know more. They want to learn more. They're actually eager. And finally, be nice, right? This is the golden rule. And it's really, really amazing how far this alone will get you. And I think that's a really useful reminder. Last, I'm going to end with just some take-home points to just tie everything up from what we've covered today. So we found, hopefully you were able to see, that a year-long PCOR CER curriculum for BHCHP staff and consumers enhanced knowledge and built confidence around this topic area. We found that interactive techniques and real-life case-based examples were very important for both staff and patient participants. And we found that for consumer patient participants in particular, it's really important to continually reinforce the distinction between wanting them to be an advisor in research versus a participant in research. Many of our patients have never been asked to advise. They've only been asked to give them the data, to participate as a participant, as a quote unquote subject in the research. And many patients will bring that mentality in, but we want to empower them to see themselves as contributors. Next, there's substantial interest among both staff and consumers to learn more about research and contribute to it as partners. And finally, incorporating PCOR and CER concepts into research or QI to homeless healthcare organization, we found is very intuitive for a lot of HCH folks. HCH folks are very inclusive minded. They're like, of course our patient voices matter, right? And so that idea is really intuitive for people, but we found it still requires some deliberate action to actually deliver on, because it's hard to do. And for us, we found that one way to do that was to very clearly go through a process of setting an agenda. And second, to very clearly develop a set of strategies to promote sustainment of this work. So we'll end there. Feel free to write questions into the Q&A. We can address them verbally. There was one question that I addressed in writing while Faye was talking. We are happy to take questions. We thank you for your time and your interest in this.
Thank you so much, Travis and Faye. If anyone has questions that they would like to verbally say, you are also welcome to raise your hand. We can let you unmute and ask your questions. Wanted to just highlight the thanks in the chat and Latrice's comment about being a CAB member and taking notes and participating in research groups. I think this conversation is so timely with conversations that have been happening amongst the Council's National Consumer Advisory Board, and really just interest in how we can ground research in the people that are impacted by the work that we're doing, and how important that trust building really is. So just really appreciate you sharing your experience and hopefully inspiring some of the folks on the call to join in. Well, We are waiting. I put a link in the chat for the CMEs. If you are interested in claiming your credit, you are able to go there. We do have a question from Devora Keller. So how have or will you be tracking what research projects grow out of participation in this training?
Great question. We track everything. So anytime someone comes to us with a research project, we have a pretty clear process for how to go about doing that. It's a great idea though, for us to very concretely and overtly flag for our own recollection and for posterity how much of this is generated by the work that we did with this 2-year award. I think that's a great idea. Thank you for sharing that.
More thanks in the chat and praise for the presentation. Give it just another moment.
While people are thinking about their questions, I'll just make a quick plug for those who are going to be at the National Healthcare for the Homeless Council's annual meeting. And in a couple of weeks, we'll be doing our annual What's New in Homeless Healthcare, no jargon summary of the latest research. It's always a highlight of my year. And please, if you're going to be there, we'd love to see you. Feel free, though I recommend registering in advance for that. And feel free to come up and say hi before or after that presentation. I'll see you in Baltimore.
Plan to be there early. That session is very popular. We'll also have some other great sessions around consumer involvement in research. So kind of continuing to build on this conversation. So we'd love to see you all there.
And then thank you again, Devora, for the follow-up. Would be cool to evaluate those studies for fidelity to the ideas taught. I agree. I think that fidelity, particularly the PCOR principles and concepts, is important. It's easy to talk about. It's hard to do. And so I think that it's worth us being really intentional about that. Thank you for the suggestion.
We have time for one more question or comment from folks. I'm going to put the CEU information up one more time. Otherwise, thank you again, Travis and Faye. We've had the chance to talk with a few folks who participated in this process as members of the lived experience group, and they have just talked so much about how much they appreciated this process and how much they learned and how much they enjoyed being able to be part of kind of, like you said, not just a subject, but actually part of advising a research process. So know that this is well appreciated by folks that you worked with too.
Great feedback. Thanks, Lauren.
Yeah.
Thank you so much. Thank you, everyone.
Have a wonderful day, everyone.
Thank you.